So today we'll have Dr. Lal who's going to speak to us on anesthesia and how safe it is. Dr. Lal, may I welcome you?
Thank you, Dr. Vishwat. Before starting, actually I want to congratulate Dr. Vishwat for taking our CPD to great heights. A couple of weeks back, I got a mail from him. This is a mail actually stating the ground rules. You are allowed only 20 minutes, 10 minutes for question and answer session, and the presentation and on the procedure of the previous day, and keep in mind the sensitivity of the audience. That I like very much actually. Doctor, you be careful. You be careful. So thank you very much, Doctor.
I also did this. Nobody understood what I did.
So I'm allowed 20 minutes. So I think my time starts now. Once it goes beyond, please, sir, please raise your hand. Coming to anesthesia. Always I looked upon anesthesia with great wonder. Because after my MBBS in 1990, completing my MBBS, I joined in a medical college in Kerala as a lecturer in anesthesiology. At that time I don't know anything about anesthesia. And the first day I saw surgeon is doing operating surgery on the patient's leg actually under spinal anesthesia. And the patient is watching. I was surprised actually. A patient is enjoying his operation doing in his own body. That really impressed me. And later, under general anesthesia, surgeon is allowed to do any amount of cutting, stitching, then nailing, screwing, all sorts of things, any amount of time, and after that, the patient is coming out as if nothing has happened, and they are asking, is it over? Isn't it a miracle actually? So that impressed me, and that failed me to drag me to this anesthesia actually. Then, but people coming to anesthesia, they have a lot of concerns. During the time of pre-anesthetic checkup, only we will know what all things are there in the minds of the people. Some people, they don't want general anesthesia. They say that, see doctor, if I go into the sleep, okay, you are putting me in sleep. But what happens if I didn't come out of anesthesia? So they are afraid of general anesthesia for that. And then some people, they tell that, okay, you are putting me in sleep, but whether I will not experience any pain while the surgeon is doing the surgery, doing cutting, and what will happen after the surgery, pain, I am worried about the pain. So they have a lot of concern about the pain. Then certain people, they are very much worried that if the surgery prolongs, whether I will get up in the middle of the surgery and see the surgeon is doing surgery, it's really embarrassing. So that concerns certain people, especially under spinal anesthesia, after giving spinal anesthesia, they will not feel the lower limbs, etc. So many a time we will see that after giving spinal anesthesia, they are just touching the thighs to make sure that the limbs are there, legs are there like that. So they are worried about whether that paralyzed remain forever. Certain people, they will have, if you tell about the spinal anesthesia or a period, they will tell that whether it will carry on for chronic back pain or chronic mobility. So these are the concerns of the patients. So we have to address the concern, and best time is at the time of pre-anesthetic checkup. Then only we have to sort it out their concerns actually. Then anesthesia actually is an iatrogenic thing actually. Doctors, we are inducing a physiological change to give anesthesia. So it should be given in a proper way, otherwise it can we will land up in a lot of morbidity and mortality. So definitely anesthesia is a high risk activity. In short actually, we will see how safe anesthesia or how safely we can give anesthesia. We're coming to the statistics actually in 1950, there's some 70 years before, there's no anesthesia department, there's no proper anesthesia people. Only surgeon used to give anesthesia, and they put the tube and give the bag to the sister will squeeze the bag. In between the surgeon will say, give some relaxant when they feel that the muscles are tight like that. And gynecologists, they used to give spinal anesthesia and they themselves do the cesarean section like that. That was the previous time. But the problem at the time is that the mortality is very high. So 1 in 1,000. So at that time, if you tell anybody you have to undergo surgery, it's a nightmare, not only for the patients but to the family as well. So they don't know the patient is going inside to the theatre will come alive. There's no guarantee actually, come alive out. So if you see during that time, any surgery, the patient is coming to the theatre with a big crowd. their friends, relatives, everybody will come because they are not sure that the patient will come back alive. So that's the situation at that time. And in 1970, actually, again, slight improvement was there. It's 1 death per 5,000 anesthetics. And in 2000, the statistics says that it is 1 death per 300,000. The safety has improved a lot. And also, the complication rates are also considerably reduced. So, this is the case of an ideal anesthetic. You should have a good mind, you should be a good mind reader, always thinking about spoils count and blood loss. You should have eyes all around to look up the machine, monitors, IV fluids, patient's face, surgical field, etc. And they should have a perpetual smile. Always they should smile. Whatever insult they get from patients, bystanders, surgeons, and colleagues. That's the ideal one. Then they should have a neck, should rotate 360 round. They should look around, and they need 10 arms to take adjustable drip regulator, hold the mask, use the mask, and then hold the thumb, keep the fingers on the pulse. All sorts of things they need more, and they need a small stomach. Many times they cannot. Many times they cannot take food, so they will have small stomach. They will have big bladder because many times they cannot go to the washroom. They will have wheels as if they have wheels under the foot because they have to move very swiftly like that. This is about the ideal anesthetic. But in spite of all that, complications are there because patients coming for surgery, they have a pathology, some problem for which they are coming for surgery. On top of them, that they will have additional comorbidities like uncontrolled diabetes, hypertension, cardiac problems, and renal and other problems actually. So naturally the complications are there. Let us see what are the complications that can arise following anesthesia. There are major complications and minor complications. Major complications can go cardiac arrest, perioperative myocardial infarction, aspiration, especially if the elective surgery patients in full stomach. Then anaphylaxis. We don't know which all patients will go for anaphylaxis, and then drug toxicity or overdose can occur. Again, awareness, sometimes immediately the patient, they will come to know everything, but they cannot respond. Then convulsions can occur. Then nerve palsies, organ injury, and malignant hyperthermia. So these are the major problems which encounter following anesthesia. There are few minor problems which will settle within a few hours, or definitely it will not go beyond 24 hours. They are dry mouth because immediately after surgery, the postoperative they will complain of dry mouth. Then damage to mouth, lips, tooth. Then postoperative nausea and vomiting. Then sore throat, especially if you put a electric tube or LMA, they will have complaint of sore throat for some time. Then persistent sedation in the recovery room. Hemodynamic instability, immediately they will have some hypertension, hypotension, bradycardia, tachycardia. Then they will have shivering, some people. Then they will have delirium, they will start talking, all sorts of things, and later they will not remember that. And then organ dysfunction and cognitive defect. Cognitive defect and loss of memory sometimes short-term can occur. And again, the cognitive defects depend upon the duration of surgery. The surgery duration of anesthesia, if anesthesia is prolonged, then the chance of cognitive defect and loss of memory will be more. And moreover, the age is beyond 60 like that there also their cognitive defects more. So our aim is to give anesthesia as less as possible to reduce all the minor as well as major complications. Then not only patients, the people working in the OR also are at risk. So 5 years back, a national-wide study was conducted in India from Pondicherry. Actually, they gave online survey was done, and 9,974 anesthesiologists are involved. And the results were quite alarming. They found that the risk of anesthesia practice people on reproductive outcome. And they said the conclusion was the people who are working in OR, they are difficult to conceive. The infertility is a problem, people working in OR. Not only that, actually spontaneous abortion and birth defects are much more in female anesthesiologists working in OR during the first trimester. So, birth defects like urogenital problems, renal problems, cardiac problems, autism, and then musculoskeletal problems, then neurotube defects, all sorts of things are there. So it's quite alarming. Not only for the female anesthesiologists, even the spouses of male anesthesiologists, it is found that the first trimester miscarriage is much more than the general population. They are saying that because of the constant exposure of gases, there is aberration in the DNA for the even males, and that will be transmitted. The chance of first trimester abortion is more in the spouses of male anesthesiologists. But as a personal note, I usually experience that there's a lot of DA cases that during that time I will have a good sleep when I go home actually. So regarding the mortality of general anesthesia, we should not worry much about the mortality of general anesthesia because 2013 WHO released a global status on road safety, and they found that RTA mortality is 18 per 100,000 per year, people per year. And when we come to GA mortality, is actually, and the RTA mortality is increasing now, but the GA mortality is 1 in 300,000 and it is coming down actually. So a patient has higher chance of dying from RTA than from exposure of following a GA. So we should not worry much about the mortality after GA. So what makes anesthesia safe? So the first safety factor starts from pre-anesthesia checkup. So some of the surgeons, they think that pre-anesthesia checkup is a waste of time and they will never, usually they are very much reluctant to send the patient to pre-anesthesia checkup even after repeated requests actually. It is not like that. So during the pre-anesthesia checkup, we have to address the concern, we have to clarify the fears and anxiety, then we will come to know the diagnosis, what type of surgery, and if there any allergies there, and any past medical and surgical anesthesia history, if there is any untoward problem happened before, then relevant medications, which all medications we have to stop before and which have to continue on the day of surgery, then any abnormal lab values investigative features, because we are taking a patient with some problems for which the surgery is posted. On top of that, our aim, we are inducing, by giving anesthesia, we are inducing physiological change. So for that, we will try to bring the patient as optimal as possible, as normal as possible if time permits. Then only we will start giving anesthesia. That is to improve the safety factor. So only pre-anesthesia checkup will come to know all those sorts of things like that. And this will help, pre-anesthesia checkup will help to plan the surgery, and we can, any crisis or any problem we encounter during surgery, all will be known only from the pre-anesthesia checkup, and we will be prepared to tackle that crisis or problem. So that will be done by the pre-anesthesia checkup. So pre-anesthesia checkup is a vital thing for the safety of anesthesia for the patient. Not only during the pre-anesthesia, intraoperative also, for providing safe anesthesia, we monitor the surgery or status of surgery, and always we see the IV axis and monitoring that. And airway management, always we put the tube and we will manage that one. We will see that the tube should not go out and like that. There should not be any kinky. Always we are managing that one. And anesthetic plan also, depending upon the current status, we will change. Sometimes we will change the anesthesia plan. Sometimes we are putting the patient on spinal anesthesia and the surgery is prolonged, then we may have to convert it to general anesthesia. So depending on the surgery and etc. plan, sometimes anesthesia plan we have to change that. So then kind of vital status. Always we see the vital status every time and see if there is any change in the vital status, we immediately interfere and then we will bring back to normal. And blood loss and volume status assessment, always we will assess the blood loss and volume status. These are all the safety factors during the intraoperative period. And according to that, we will give additional medication depending upon the vital status, etc. And always we systematically scan the machine, monitor IV fluids, patient and surgical field, and our eyes will be rotating, scanning all around in a cyclical fashion, always like that to provide a safe anesthesia actually. Then what makes anesthesia safe? Anesthesia machine. It's a wonderful thing for the safety of anesthesia. In this juncture, I remember one incident. As I told, I joined as a lecturer in the anesthesia department immediately after my MBBS. At that time, one day, I happened to be, I just went to the ortho theatre. One case is going on, it's about to finish one ortho case actually. It's a young chap, 22-year-old boy was there actually. And my associate professor, madam was there, and one intern was there in that OT. So I'm talking with the madam. So operation was over. Then madam told that guy, just case is over, so you please switch off nitrous oxide and make it oxygen. So that guy switched off the nitrous oxide and made oxygen. After some time, madam told the sister to give reversal. So the sister gave the reversal. We waited for 5-10 minutes, and I'm talking with the madam. Then still the patient is not coming out. The madam is saying, "What happened? The patient is not coming out." Then she cross-checked with the sister. Sister, whether you have given the reversal or some other drugs. So she cross-checked and she told, "No, madam, so reversal." Then we waited again, and 5-10 minutes. Still the patient is not coming out. Then madam, by chance, she looked into the anesthesia machine. So when she looked, immediately the heart stops few beats because that guy, instead of stopping nitrous oxide, he stopped oxygen. So for these 20-25 minutes, the patient is getting only nitrous oxide. So no oxygen at all. Immediately, madam stops nitrous oxide and no oxygen, but already damage is done. Patient went to pulmonary edema, cerebral edema, and the patient was immediately shifted to ICU. And on the 4th day, the guy expired. It's very sad, actually. So, see, if that patient would have been today, that patient would not have died, because today machine, we cannot give hypoxic mixture to the patient. If we stop by chance, by mistake, if we stop oxygen, naturally the nitrous oxide also will come down. We cannot give a hypoxic mixture to the patient now. So that is the beauty of today's machine. And previously, we don't have anything. We have to squeeze, even in the middle of the night also, we have to squeeze only. But now this machine, we can put it on volume control. This machine will take care of all the ventilation part. So that's the machine plays a very vital role in providing safe anesthesia. And we have a very good machine actually. Monitoring equipment, again, when I started, there's not much monitoring equipment. Always we keep 2 fingers on the pulse, and in between we check the manually we check the blood pressure, and there's no pulse oximeter. At time we look at the blood every day, discoloration, blood becomes too dark, then we will come to know that oxygen is less, then we will increase the oxygen. So these are the only monitoring equipments we have. When we get a patient, we start the stethoscope with plasters in the chest, and we always listen to the heart sounds. These are the only monitors available at that time. But now it's not like that. We have very good gadgets. If any deviation, immediately alarm will be set, we will come to know. So now the safety is added a lot actually. Then now we have safer drugs and equipment. Then advancement in airway management is fantastic actually. Previously when I started at the time, if we cannot intubate, nothing else is there. Now it's not like that. We have a lot of choices are there. We have LMA, ProSeal, everything is there. And fiber optic endoscope is a wonderful thing that we got a year back. Actually, with the fiber optic endoscope, we are sure that we are so confident that we can secure the airway. However obese the patient is, that we never failed till now with the fiber optic endoscopes. So a lot of advancement in the airway management has come. Then definitely anesthesia skill and knowledge. Then we just go on with the guidelines, protocol and checklists. This is for the safety of the patient and to prevent errors which usually happens. So to prevent that one, we usually follow the guidelines, protocol and checklists. And definitely surgical skill has also improved. The duration of time of surgery is reduced, thereby it added on to the safety of anesthesia. So safe anesthesia, actually a pilot before starting the flight, they will check the cockpit. Like that daily we check our anesthesia machine for any leak is there, or then we will calibrate the oxygen sensor or in flow sensor, everything we calibrate, and we will check the backup equipment and other devices. Every day morning we will check up that and label all the medications. That's very important to avoid the medication error. It's very, very important because anybody cannot come and work in anesthesia. They need some training. They should know what all drugs which we are taking, and we are so particular that always it will be loaded in the syringe and it will be labeled actually. And the people handle will be few because they know the drugs about that. The person who handle draws will be there for giving the drugs, because the problem is the IV medications. Once we pushed it, we cannot take it back. So that's why we are very, very particular. We see that it should not happen like that. No medication error should happen. So always we are very much particular in that. And always we keep it ready with all the equipment to tackle any unexpected problems. Usually we land up in unexpected difficult airway. So we think that airway is okay, but at the time of intubation, when we looked up, we cannot see anything. So immediately we will take fiber endoscope or element. So everything will be kept ready. So always we are ready for the safety of anesthesia. So we have all proper armament there to provide a safe anesthesia. And safety factors starts with the preoperative assessment. After that, we will plan the surgery, and during the operative day, we check the machine and monitors. Then we prepare a patient workspace to see the machine monitors and patient and surgical field. Then we check the backup equipment. Everything is ready. Then always we label the medications to prevent as a part of the patient safety strategy. Then, in spite of all that, sometimes accidents can occur. It's a multifactorial thing, and main cause is system failure. These are all electronic gadgets. Sometimes it may fail, so we'll be very much careful. That may be the cause, and we always be aware of that. And then human errors. If we deviate from the usual policies and guidelines, the chance of getting error will be more. And so we always stick on to the usual policies and guidelines. And many a time, a human error accident occurs. For a simple case, we never expect any problem. So that time there will be a laxity in the vigilance. In such cases, always we will have a big problem. So we are so particular, even if it's a small case, we will not reduce our vigilance. Always we are vigilant because we doesn't want any accident to happen. then a lot of errors are already documented. So we are very particular to see that errors should not happen, especially airway error. So even at the insertion of the endotracheal tube, we make sure that it is in the trachea. We have now gadgets to know that whether it's gone to the esophagus or gone to endotracheal tube, ETCO2 is there, when we auscultate the chest, etc. And then once it intubated, it should not, we see that it should not come out actually. Especially if we change the position from supine position, if we change the patient in the prone position, then during that time, sometimes the tube will come out. So we are very particular that it should not happen, so that we have reinforced the tube twice with the dynaplast, and on top of that we will reinforce with the offsite also. So it should not come out, because if the patient in this prone position during the middle of the surgery, if the tube comes out, it's a disaster. We cannot turn the patient back, we cannot intubate in that position. So we are very particular to see that it should not happen, and we are very careful that till now we don't have any problem till now. Then position errors. During different position, we are very much worried it should not happen any problem with the eyeballs or any pressure points. We take care of that to avoid position errors. Medicine errors, I told that we are very particular that there should not be any medicine error. Till now we don't have any medicine errors, thanks to our good anesthesia technician and other team actually. Then procedure errors. Sometimes there are procedure errors can occur, though we try our best to avoid procedures like inappropriate IV injections for local anesthesia. Every time we aspirate in between to see that there's no blood is coming out, it's negative for blood, and then we proceed. And also epidural hematoma, we see all the precautions to avoid this epidural hematoma. If the patient is taking aspirin, we stop the aspirin 5 days back, and we take all the precautions for that. And human errors, sometimes if we deviate from the accepted anesthesia practice, we may land in problems. So we always stick on to the accepted anesthesia practice. And also fatigue, because we see that if they should not fatigue should not be a problem. If they are late night, we give them adequate rest like that. Then apart from that, we have additional factors are there increasing the anesthesia risk. From the patient side, if the patient is having age factor, younger age or old age like that, with comorbids can cause a problem. Then procedures, sometimes elective cases, you don't have much time to optimize the patient. In such cases, it gives a risk actually. Then depending on the resources, equipment and monitoring facilities of our hospital, in that we are very much rich actually. We are very much lucky to have good resource and equipment and monitoring facilities are there. So that if he doesn't have all these things, then it causes additional risk for the safety. And we have skilled anesthesiologists and surgeons, and always the physicians are ready to help us out if we land up in difficulties. So these are the additional factors, risk factors for the safety. Then altogether the safety starts with the patient, and then it go on to the facilities of the hospital, then depending upon the anesthesia skill and as well as surgeon. So it's a teamwork. So all of this includes for the safety factors, patient, equipment, skill of the anesthesia, skill of the surgeons for the safe anesthesia. So always we try to improve the quality of care. If we improve the quality of care, the safety will improve actually by observing the standard protocols and guidelines. Always we have a constant vigil to the monitors. If any problem occurs, like immediately we have a constant vigil, and even a small change, attention to the detail. If any slight change in the vitals, immediately we interfere. We will not wait till the problem goes to the bigger problem. So constant vigil is there. But still, in spite we are human beings, sometimes we may have mistakes. So, but we learn from the mistakes and improve, and we have a proper documentation. This all adds on the safety of anesthesia actually. Thus, we always try to make anesthesia miraculously safe. Then, I believe that patient safety starts with me. Each one of us, the patient coming for your anesthesia clearance, the patient sitting other side of you, you should believe that safety of that patient lies in you actually. So altogether, it's a teamwork actually. Altogether, we can make anesthesia a miraculously safe thing. Thank you.
Thank you, Dr. Lal. That was a wonderful presentation on anesthesia and how safe it is. So we'll go to the question session. Anybody has questions?
So you mentioned about that study in Pondicherry.
Yeah.
What was the suggestion? You said
Suggestion actually it's like that, see, because the thing is that that's why now
What can people, what did they learn?
that's what we are learning that a lot of things are there now, newer things are there to reduce that one. Because now we have a scavenging system that whatever gases coming, it will not come to the air, it will be taken out and given to that so that the our atmosphere will not be polluted, number one. Number two is that if you are too much busy, it's better to move to some other less busy theatre, or they can take first trimester. That's a much crucial time. It's better to take. So, but certain really anesthesiologists they will take leave actually for the first 3 months actually, because they will trimester. So whatever best possible we can do because of the newer things that.
Is that hospital will need a gas?
Yes, it's possible. So that's why we have a scavenging system. It will absorb the whatever expired gas is coming, spillover gas is coming, it will suck into them, and that thereby it will be less polluted. In spite of all that, sometimes definitely the atmosphere, OT atmosphere is little gas will be there. It will be there. Yeah.
Is that the reason why you laugh so much?
I don't think because yeah, that case all should be laughing like that.
But I know the image that you showed earlier, multifaceted, anesthetists has to do a lot of things. When a person has to do so many things together, obviously it means that anesthetist is under a lot of stress. So how do you deal with stress? Because dealing with stress is important for the safety of the patient as well.
It's a wonderful question actually, because many people they don't know that we are undergoing so much stress. Many people they don't know the anesthesia, even a department is there. If any something, that's what Abubakar was telling me. See, if any surgery goes well, the credit goes to a surgeon, and they will not know such a poor anesthesia people with so much stress is doing all the wonders like that. Second thing, if any problem occurs, they will. It's all because of anesthesia. It's all because of because we will not come into the picture. They are very safe that we will not talk to the patient after that. So whatever problems come, they will put everything on anesthesia. Yeah, that's what I'm telling you. We have a lot of stress, not only doing our work, the anesthesia itself is a stressful thing. And nowadays the job is made easy because of the monitoring facility, because of the good equipment, anesthesia, and good colleagues. So that's what stress is there. So we find time. Laughing is one of the methods of stress relief like that. We'll talk to each other and social gatherings, first days. These are some of the ways of reducing stress.
Excellent, excellent. Anybody else?
You said like the cockpit, they check. Do you have any checklist in that?
Yeah, definitely. We have a checklist. Not only that, every morning we'll come and we'll check the machine first. Whether it's a leak is there or oxygen sensor is working. We have checklist, everything is there, and we will see that all the equipments are there.
Yes, you tend to miss some if you don't.
That's right. Checklists are there. We are checking checklists that's going on. So that's what, because Dr. Michelle once told that it is because of the checklist. Why they brought is from the by the cockpit itself. They found that the errors are less if you have a checklist like that. So we are doing that checklist like that.
Not only that, when we are doing this checklist is used into the recorder. If you say our anesthesia machine, whenever in the morning we are checking, the date comes and whether at what time have we checked the anesthesia machine. Similarly, our crash part, if we are defibrillator, whenever we check it, that it goes in the record. So it is not only ours, it can be retrieved also from our record.
And we cannot bluff it also. Suppose if the anesthesia technician says that we check because it is coming there, then if you look at that, we'll come to know that whether they have checked at what time like that.